The radial head fractures are common injuries. Still, there is no consensus on most of the displaced and complex radial head fractures. I would try to cover those topics in this talk. Historically, radial head used to be considered expendable, but after extensive biomedical and clinical research, it is now universally accepted as a vital elbow structure for forearm and elbow stability. Radial head is an important secondary stabilizer of the elbow. If the medial collateral ligament is incompetent, as shown in this biomedical study from the Mayo Clinic, radial head is also important to maintain the stability of the elbow by tensioning the lateral collateral ligament. It also resists the proximal migration of radius when the arm is axially loaded. In the posterior lateral rotatory instability described by Sean O'Driscoll of Mayo Clinic, lateral ulnar collateral ligament is damaged and the repair of LUCL is less successful in the absence of radial head, further showing the importance of an intact radial head in the elbow function and biomechanics. The injuries to the medial collateral ligament is much more common with radial head fractures than commonly believed. They can be quite subtle, so one needs a high index of suspicion. More severe the fractures, the more chances of associated medial and lateral ligament injuries. According to a study by Itomura from Japan, type 2 and 3 Mason radial head fractures, in more than 50 to 80% of cases, there are ligamentous injuries, although not all clinically significant. The bruise on the medial aspect of the elbow, as shown here in the picture below, is an important indication of injury to medial collateral ligament. And if one finds it, the medial collateral ligament injury should be excluded clinically by MRI scan and if necessary by examination under anesthesia. So the radial head should not be simply excised, but it should be carefully considered and then only excised. The treatment of radial head fractures, like many other conditions, varies on several different factors. Patient factors include the age of the patient, occupation, whether the dominant arm is involved, and the overall personality of the patient. The fracture characteristics influencing the treatment would be not only the number, but also the size of the fragments, their displacement, if there is articular damage, what is the bone quality, if there is a metaphyseal bone loss or comminution, and are there any pre-existing degenerative changes. The standard AP and lateral view X-rays are always done. Sometimes this particular view called Greenspan Norman view, which is an oblique view of the lateral view of the elbow X-ray as shown here, is required. If the X-rays does not show any bony injury, then sometimes a posterior fat pad sign is an important pathognomonic sign of the fracture of the radial head. This particular X-ray shown on the right here, it is one of the patients I saw recently. It's a young Russian woman, injury to the elbow. X-rays did not show any serious injury, but she told me that she gets intermittent locking and severe pain of the elbow. I got suspicious and got a CT scan done, and this is what the CT scan showed. So it's not only a displaced radial head fracture, but also other associated injuries are part of terrible triad complex, and she required full house. So the CT scan is an important investigation. If the morphology or the type of the injury is not clear from the X-ray, it gives important information, especially the 3D reconstruction for planning the treatment. The majority of the radial head fractures are undisplaced or minimally displaced, and they can be treated non-operatively. A good indication of fractures for non-operative treatment is the range of gentle passive movements after aspiration of hematoma and injection of local anesthetic if necessary. In my view, if about a 50% range of movement in flexion and pronosupination axis is present, that fracture can be treated non-operatively. It is important to reassess these fractures at 2 weeks' time, both clinically and radiologically, and if necessary, alter the treatment if the clinical and radiology pictures have changed. It is these displaced type 2, 3, and 4 fractures for which there is no consensus of the treatment, but one thing is certain that these fractures require surgery or various types of surgical treatment. The surgical treatments normally has three options. Either the fracture can be fixed by screws or the plates, it can be excised, or a prosthetic replacement can be put in along with the excision. While there is a general consensus that Mason type 2 fractures should be fixed, there is a lot of controversy about type 3 and 4 fractures in terms of whether they should be excised, fixed, or replaced, and especially if these fractures are associated with other injuries. This is one of the algorithm suggested by Mayo Clinic for treatment of these fractures. This is just one view. There are many different views and different opinions about how these fractures should be treated. What I believe is that the surgeon should start the surgery with an open mind about fixation or replacement of the treatment. Internal fixation should be attempted up to 4 fragments unless the fracture is clearly unfixable on preoperative imaging. And the final decision to excise or replace the radial head should be taken on the table. It is not just the number of fragments, but also the size of fragments that are important. There may be 2 large fragments and 2 or 3 smaller fragments. The smaller fragments can be excised if the large fragments can be fixed satisfactorily. I would fix if it is possible to retain up to 80% of the radial head. I have done a decent number of these fractures and I have come to that conclusion, and the data is going to be published soon. The availability of the smaller headless cannulated screws of the size of 2 millimeter or 2.5 millimeter has made life easier, and it is possible to fix even the smaller fragments. The pictures shown in the upper two pictures are definitely quite comminuted and significantly displaced fractures. There may be different views about treating these fractures. I fix them, and the post-fixation pictures are shown in the bottom of the slide. And fortunately, I was able to get good fixation and good results thereafter. These fractures should be operated as soon as possible. Although I understand that in Indian circumstances, a lot of time patients present late. So my view is that you can fix these fractures unless the healing has happened. I would show you some x-rays later about the late fixation of these fractures. When you decide to take the patient to theaters, it is important to do some pre-op planning. Image intensifier obviously is necessary. Along with that, even though you may feel that this fracture is fixable, still it would be logical to have the radial head replacement implant and instruments available, because the surprises do happen, and sometimes the fractures which seems fixable, when you try to fix them, they just fall apart. The headless cannulated screws of different sizes are available, so that shed should be there. And if you fancy putting the plate, then the relevant instruments and implants should be available. I normally operate radial head fractures with the patient supine an arm on the arm table on the side, and and in that position you can go medially also if necessary. The arm has to be kept on the chest. Sometimes if you have to operate the patient on a lateral position, thinking that you might need a posterior approach. In that case, keeping the arm on a Mayo table as shown on the picture on the right, the lateral approach can very well be done. The uh, the standard approach for the radial head fractures is any one of the lateral approaches, whichever you feel comfortable with, any Cocker or its modifications. Quite often, the lateral collateral ligament and common extensor origin are avulsed or torn, and you can find a rent in the muscle and you can go through it. The injury to the posterior interosseous nerve is always a possibility, and it should be kept in mind. Keeping the forearm pronated and not putting a retractor on the ulnar side of the radius would reduce the chances of injury to posterior interosseous nerve. Uh, you can use a posterior approach if you're not sure about the nature of the injury or what you're going to do with it. I always use headless cannulated screws for fixation of radial head fractures. I normally use 2.5 or 3 millimeter screws. Now the 2 millimeter screws are also available, and they are useful for fixing very small fragments. If you fancy putting a plate on, which is indicated in very small cases, then you can use the plate and screws. There is evidence in the literature that in the similar fractures, the screw fixation gives better result than the plates. I would request you not to use just the K wires with the impression that it would hold the fracture. It would not, and you would have worst of both worlds.
You
The
need to.
technique of using the headless cannulated screws is quite simple. I normally extend my incision slightly proximally and detach the common extensor origin anterior and posteriorly to give me more space. The screws are put over the guide wires, so there is a very little chance of you going wrong and putting the screw in a wrong position. There is no limitation as to where you can put the screws. You can go through the articular surfaces, and that gives a lot of freedom about putting the screws in various configuration and various places there. The radial head can be very securely fixed by using these techniques. These screws are self-drilling and self-tapping, which makes life easy. There is a small role for arthroscopic assisted fixation of radial head fractures. I must confess that I have not used it, but in a simple fractures, I believe this can be used. The screws have their own share of complications like any other technique. Backing out of the screw can happen, and if that happens, you have to go in and take the screws out. Non-union can happen. In this patient who is a physiotherapist, I got both these complications, but the patient has minimal symptoms, and in spite of radiological non-union, there was some fibrous union. And once I took the screw out, the patient was happy, has a good range of movement, and is stable and painless elbow. HO and stiffness can also develop. It may require arthroscopic excision or sometimes excision of radial head. In this patient, I offered him to do his repeat surgery, but he has minimal symptoms, so decided not to get for it. Sometimes the elbow can become painful and stiff, and in that case, if nothing else works, you might have to revise do a revision surgery and put a prosthesis in. In the fractures where there is a metaphyseal comminution, the plate would be indicated. In this patient, which I did recently, because of the angulated and displaced radial head, there was a rotational block. So once the fixation was just done, and with these intraoperative pictures, as you can see, the bicipital tuberosity in one picture is on the lower side and one on the superior side. A full rotation was achieved after the fixation. The position and approach for the plating is almost the same as the screw fixation. The only thing is that you need a bigger incision, and posterior interosseous nerve is more at risk. There may be problems post-operatively because of the prominent metalwork in the subcutaneous location. And so in about 70% of the cases, the metalwork need to be removed. If you're putting a plate, it should be put in the safe zone of the radial head, which is the non-articular one-third of radial head. And if you keep the forearm in neutral rotation, it would be the radial head looking laterally. It can also be found by the area opposite the bicipital tuberosity or the area between the styloid process and listus tubercle, uh, as seen in this picture here on the right. Uh, the excision of radial head would be required on a small proportion of patients, especially in the elderly population, and usually Mason 3 fractures without significant associated injuries, or sometimes if the fracture is associated with the pre-existing radiocarpal arthritis. If you're excising the radial head, all the fragments should be excised, but no additional bone should be removed. It would be sensible to check the varus, valgus, and axial stability after excision of radial head. And in a small proportion of cases, if the elbow is quite unstable, there would be a case for putting a radial head prosthesis. There are several reports in the literature of the long-term satisfactory results after excision, but only in the right patients. This procedure has its own complications, mainly because of the proximal migration of the uh, radial radius and the loss of the lateral buttress of the elbow joint. It can cause the ulnar wrist plane instability of the DRUJ and sometimes heterotopic ossification, degenerative arthritis. So one has to be very careful when deciding to simply excise the radial head. In the Mason type 3 and 4 fractures with unreconstructible radial head and significant associated injuries, prosthetic replacement of radial head has a role. The radial head prosthesis has three main variables. They can be either monoblock or modular. The stem can be either loose fitting polished stem, cemented stem, or a press fit stem, and articulation can be either fixed or mobile. The modular prosthesis has largely replaced the monoblock prosthesis because it gives the flexibility to choose the size of the radial head and the length of the neck on the table. I normally use the loose fit modular prosthesis called Evolve with a polished stem. It is simply to align the articular disc with the capitulum. It's a quick and easy operation with a short learning curve, and there is usually not any major complications. Bipolar stems are preferred in revision situations because alignment of proximal radius is altered and fixed articulation can cause subluxation, dislocation, or capitular erosion. Overstuffing of radiocapitular joint is an important complication of this operation. It can be avoided by intraoperative X-rays in which the ulnohumeral joint line should be seen parallel and the prosthesis should be aligned with the proximal margin of the radial notch of the ulna. After the procedure, the lateral collateral ligament and common extensor origin should be repaired, which are usually ruptured. Sometimes you would see this appearance in the X-ray where the elbow joint looks some diastasis. It is there because you have opened from the lateral side. Once you have closed the wound, this should disappear and one need not to worry too much about it. Articulated X-fix would be required in a very small proportion of cases where elbow remains unstable after fixation. I normally do not put any plaster and elbow is mobilized as soon as possible. I've done some delayed fixation. This is a 71-year-old man who came to me 2 months after the fracture. He was physiologically younger and used to play golf regularly. So I decided to fix it. And fortunately, he got good result as seen here 1 year post-fixation X-rays. This is a very interesting case, and a Spanish school teacher who came to me from a different hospital where he had the first surgery in which the half of the radial head was thrown in the bin and the other half was lying on the medial side. I fished it out and fixed it and put the articulated external fixator. He worked hard, and in the end, radial head fused, united, although there was some laxity there, but he had a reasonably stable elbow, painless and good movements. Uh, he's doing quite well, but I do not know what happens 10 years down the line. The take-home message for my talk would be that radial head is an important secondary stabilizer of the elbow, especially when MCL is incompetent. It also stabilizes the elbow by tensioning the LCL, so it should not be excised without a serious thought about it. Radial fractures, if possible, should be fixed with the headless congenital screws. It is possible to get good results of fixation even if some small fragments are excised, and delayed fixation of radial head is possible. Do not overstuff if you are doing a prosthetic replacement. Many thanks for your attention. Most of my talk is based on this paper, whose reference is there. Since this talk would be available to you later, so you can use this link and regain this paper. This is my email if anybody wants to ask or send any questions to me in future. Thanks very much.